Welcome to the HealthspanMD podcast. Welcome to the HealthSpan Podcast, where we talk about the science of longevity. And today I'm honored to have Dr. Mary K Geyer, a naturopathic physician and founder of Empower Integrative Health here in Scottsdale, Arizona. She's almost 20 years of experience now doing this, specializes in addressing complex chronic conditions. In this episode, we're going to do a deep dive into her methodologies, her perspective on the evolving landscape of healthcare, and her insights into achieving longevity through holistic and integrative means. Welcome to the HealthSpan Podcast, Dr. Geyer.
Thanks for having me. I'm so excited.
I'm very intrigued. I mean, I just, we met recently through a professional organization. I really liked your clear passion for patient care. It just emanates off of you. But you said something at a recent meeting that just really struck me, and you said, "I'm the weird shit doctor." And I took from that you really enjoy seeing complex patients without easy answers. How did you develop that interest?
I'm not totally sure, actually. It gravitated towards me when I was in residency, and I'd had my own medical issues when I was growing up, and then that had changed my trajectory because I was going to be a DO originally, because I liked, the integrative aspect of it and thought DO was the only thing I had as an option.
Right.
And then I had my own medical issues, and then while I was in medical school, I had a child who had a bunch of developmental delays, and so we went down that route and rabbit hole and lots of specialties, and so what I thought I was going to do was substance abuse and recovery, and took a huge turn from that during residency and just started delving into subspecialty rotations with everyone I could possibly find. And then I just got into the weird shit, and it just kept coming to me.
Yeah. It found you then.
It found me.
Yeah.
Isn't it funny how that happens?
Well, it's such an interesting thing because my background was Mayo Clinic for 20 years, and that's the place where people go that can't get answers, and generally they don't get answers there either. It's a frustrating experience. Most of the time, we repeat all the tests that have already been done. They all come back normal or whatever, and we say, I don't know. I don't know what this is. And, but that being said, every once in a while it was like, oh, well, did anybody think of this? And then that was a really cool thing. When you see these complex patients, what's your kind of strategy? Like, how do you go about trying to solve these issues for them?
Part of the issue that I saw in medicine is just listening. So we create a timeline of their health, right? And we don't have that kind of time in medicine where we're being managed by insurance companies.
Yeah.
And so leaving insurance made a big difference. And then when I approach them and make that timeline, I'm listening to everything, and I'm thinking about how one thing leads into the next, because we're this dynamic process, right? We're not just, our kidneys or just our heart or just any of these things, which is sometimes what ends up missing in these settings where everybody's got their specialists and they're all managing, and we're talking better, I think. As medicine, I feel like professionals and specialists are talking better and managing care better, or co-managing care, but it still is very siloed. And so it's really about looking at how these things are interrelated and how one thing can lead into the next, and how if somebody has chronic UTIs, we should be looking at their gut. Because how do women get UTIs if we're looking at women? Those kinds of things that interplay. So that's how I look at them. And then one analogy I like to use is that I kind of think of people as a chair. I don't mean to oversimplify this, but, it's like we were talking about this at the meeting, that there's the foundations of health. And so we're looking at sleep, mental health, diet, and movement. And those are really what's holding up the chair. And so the next thing is going to be the bottom of the chair, which is maybe our genetics. And so we know most things are epigenetic at this point, but those things underneath are influencing it and its stability and whether or not they're expressing. And then the back of the chair is environmental influences. And so that's, did they get exposed to mold? Do they have Lyme? Did they get Epstein-Barr and it reactivates? Did they get COVID and they've never been well since? What's happening there in this long COVID picture? And so that's kind of how I look at it, is like, okay, we have to address the foundations and the legs of the chair, or it's on the floor. And then we have to I look a lot at genetics. And then I also tell people all the time that we're doing this in a preventative aspect and looking at it like, genetics loads the gun, lifestyle pulls the trigger, but genetics is still there. And can we do things preventatively and really be proactive? And then do they need the environmental stuff? Because I don't think they always do, and it's like some people think everyone needs it. But that being said, we have so many environmental things now. I mean, the big hot new topic is microplastics, right? So, and years ago it was mold, and years before that it was, and so I think all of those things are really important, where we can address each of those for people. So that's how I look at it.
I'm interested in one of your first statements. You said that you were deciding between being a DO versus a naturopathic physician. What led to that change? Like, why did you decide to pursue the path that you did?
So, I had PCOS, and I'd had a lot of health problems. I was premature as a baby. I had kidney problems when I was growing up. It actually stunted my growth, and they didn't find it until much later when I had some pretty significant issues. And so I had a lot of experience in the medical field and poor experiences in the medical field. And so I had this idea. I had a kind pediatrician who was really wonderful. And I thought to myself, like, I want to be a good doctor. I was just a face in a hospital a lot of times, in and out of hospitals with the kidney disease. And so he was just really wonderful. And I was like, wow, I want to be like you. And then I was in school and learning about different things. And I'm like, our mind is really powerful and our gut's really powerful. And there's all these things. And so I was learning about integrative medicine without realizing I was learning about integrative medicine. And so I thought that was a more natural way and that I'd have a more integrative approach with that. But then I was 21 and PCOS and stopped getting periods for 3 years and failed the progesterone challenge 3 times. And they said, hey, you're going through menopause. There's nothing we can do about it. You'll never have kids. It's fine. We'll put you on hormones eventually. And so that wasn't enough for me. And then I just started to seek out things. I said, okay, I'm going to go to an herbalist. I'm going to go to an acupuncture. I'm going to go to a chiropractor. I don't care if somebody has rattles and smoke and whatever above me. I will try absolutely every healer possible. And I saw the value in all of it, but none of it got me better. And so I was like, okay, great. And then I saw a random ND that I did not think could help me and got a period 2 weeks later. And I have, a pretty large family, as I think a lot of people know. I talk about my family a lot. But I've had, 2 kids since, and I have a blended family of 5. So obviously I could have my kids. I didn't have any problems. So that was how it kind of changed. I learned about naturopathic medicine and decided to do that. But really my chiropractor said if I could do it all again, I'd be an ND. And I was like, what's that? And so he was the one who gave me the idea of that, to see that original ND. Mm-hmm.
I in some ways we have a shared experience. I we'll call it allopathic medicine. I mean the typical MD medicine, and I 11 years of training. With 4 years of medical school, 3 years of residency, 4 years of fellowship, and when early in my career as a cardiologist, I realized that the tools that I have, that I've spent 11 years developing, are pretty limited. I'm really good at sick people, like acutely sick people. We have brilliant therapies. I mean, things that are mind blowing, but what I'm seeing all day in my clinic is chronic disease, and all I can do is tell them, eat less, move more, and here's your prescription. And I realized if I wanted the best outcome for my patients, I needed to understand nutrition, physical activity, behavior change, sleep, but those were things that I never learned anything about. And it sounds like from your experience, you were able to recognize those limitations of our more traditional allopathic medicine and said, you know what, I want to do something different. I want to do better than that.
Yeah.
Wow. That's really great. You also alluded to this earlier as well, and I know it's a really powerful story. You went through some challenges that any parent would be that is our worst nightmare. And how did that experience, if you don't mind sharing, how did that affect you, and how does it affect you as a practitioner now?
Yeah, my son, so right from the beginning, it just, something seemed off from the time that he was born. And, at 4 months, it was like, okay, not a lot of milestones at 4 months, right? But nothing. And then by 10 months, he wasn't holding up his head. He wasn't making eye contact. He had feeding issues. So he had a lot of issues. And he was sick all the time. He had pneumonia. He had urinary tract infections. I mean, the kiddo had pneumonia one after another. And like, he was breastfed. I was so careful about everything. I was giving him probiotics. I was doing all the things. I took him to chiropractic, and like all these things, anything I could possibly think of. But there was something missing. And then at 10 months, I was on my sixth pediatrician, and she was wonderful. This wonderful DO pediatrician. She said something's wrong, and I was like, "Hey, I've seen 5 of you before this, and they were NDs and MDs, and there's good and bad in every profession,
Sure,
right?"
absolutely.
And she was wonderful, and she said, "Yeah, I think we need to work this up and start doing some, like testing, and I want you to go over to neuro, and I want you to go to endocrine because he also had an enlarged liver, and he was very small, and his head was very large, and his there was just a lot of things that were happening in all the different aspects of his health, and so we were just working everything up. His fontanelles didn't close properly, like it was just kind of one after another, and so we had all these specialists, and I'm running around to all these specialists, and we're not really finding anything. We don't know why he's not growing, or why his liver's enlarged, or what's going on. But they think he's autistic, but it's is he autistic? And he's too young, and now we're progressing through this. And so I was sitting in a pediatric gastroenterologist's office, and he was saying, "Oh, I'm convinced he has mucopolysaccharidosis, which is an inborn error of metabolism." And at that time, I was a resident. I didn't know a whole lot about it. I'll be honest. Like, I think we studied it for 5 seconds for
Right.
boards, right? Wasn't really my specialty. But what I did know is that it was fatal, right? And that I was like, okay. And he gets on his phone with his resident, and he's talking about a type 1 diabetic patient in front of me, and he's ignoring me. And then he's like, "Oh, I got to go. Well, you know what that diagnosis is. We need a liver biopsy next." And, kind of leaves. And I'm like, "So you're telling me my son is going to die by the age of 4? And you're convinced of it, but we should still do a liver biopsy." And then I like wander out into the hallway. And I always think of this with patient experiences, because I wandered out into the hallway, and I've got him and, my son in my arms, and I'm like looking for someone. And I'm like, "Hey, am I done here? Where do I check out? Is somebody else coming? Like, what's happening? How do I get this ordered?" And like, I'm literally just wandering through the hallways, like, and I was like, "This is wrong. This is all really, really wrong. Like, how this is happening, the way that it was so nonchalant for him, the way that none of this was handled, even the way that we're not really guided to our next steps in medical care a lot. It's like the doctor leaves the room, and then you're like, "Am I done? Like, do I check out? Do I make an appointment somewhere else? Where do I go for a biopsy? What's happening next?" And I was just like in absolute tears on my way home, and so I remember thinking to myself, I'm not going to do that. I need to do something different. Like, I need to be an advocate for patients. And I'm working so hard for my son right now. Like, people don't have this advocacy very readily, especially 20 years ago, right? Like, things have changed a lot. And there's a lot more advocates out there now, but that wasn't something that existed then, especially in autism. Like,
Right.
so that was my big guidance. And I was like, okay, I have got to seek out. And everyone was wonderful. I sought out like just randomly cold called people and was like, "Hey, I'm a naturopathic resident in family practice, and I'd like to come see you, and can I do some GI rotations with you and some ENT rotations, some ophthalmology?" And then I went to people that were working specifically with special needs populations and things like that. And so really seeing a lot more of the, like the 15-year-old that had been having TIAs for years, and you're like, "Oh, okay, that's a thing," So that was how it kind of developed, and then they just kind of came to me after that. Yeah.
Wow. Wow. What a story. And imagine you went through that and you were a medical professional. Can you imagine the people that just had no background and they're dealing with such complexity without that guidance? Did you so you've opened your own practice. How long have you been in practice?
6 years.
6 years. And this again is Empower Integrative Health. What led to you opening your own practice?
It was a labor of necessity. I'd always been an employee, honestly. I worked in academic medicine, teaching medical centers. I worked at Sonoran University at the medical school there for 10 years. And I was up in Oregon at NUNM, and I was the associate dean and residency director up there for a couple of years. And I'd worked in large medical centers and urgent cares. And so I'd worked, and I also worked at, started Naturopaths Without Borders. And so we started clinics in developing countries. So there's a lot of things that I had done, but I'd always had like the little comfort of being an employee, and that's very different, collecting a paycheck. And then rapidly lost my job on a Friday and was not expecting it. And I had patients to see on Monday that had nowhere to see me. And so I was like, I guess I'm going to start a website, and here's a fax number and whatever. And that was in, 6 years ago, telehealth wasn't a thing. It was like pre-COVID. So
Right.
I was like, I'm going to figure out telehealth and how to do this HIPAA compliant. And it was a very weird thing. Now it's like normal. It was like, okay, can you get on Zoom? Like, is this a thing?
I'll send you a link.
Yeah, and then I rented a 10 by 12 room subleased and kind of moved from there, and then 3 rooms, and now I've got 6 rooms and a paramedic, and I'm hiring a resident right now. So it's grown into quite the
So
yeah.
that was good, fate, right? Like
Yeah.
it just came in. I guess that's mostly life. The biggest challenges we have often end up being our biggest opportunities,
Yeah.
and you've certainly taken advantage of that. So on your website you talk about combining conventional with alternative treatments. Can you give an idea of like who are the patients that come to see you, and how do you kind of approach their care?
The patients that usually come to see me, so I actually get quite a lot of referrals from other medical colleagues, and co-manage a lot of care with them. And then sometimes they just find me. I've never really marketed, so that's something brand new to me. I've not had to. They've been all referrals for the most part, so that's been great.
So generally, that's true in medicine,
Yeah.
right? That people who do a good job,
Yeah.
you end
Yeah.
up getting full because of word of mouth. Yeah.
Yep. So, they usually find me because their doctor or, can't figure out what's going on. And sometimes it's because they just don't feel like they're getting the care that they need, like the Hashimoto's patient that's like, great, my antibodies are going up. Why are my antibodies going up? Can anyone tell me why I have antibodies? Or, lupus or one of those autoimmune conditions or several autoimmune conditions, or I do a lot of GI, a lot of more difficult like interstitial cystitis, things like that just we don't have great, and conventionally we don't have great treatments for a lot of things where we'll be like, hey, take this antibiotic, go home. Or maybe somebody's integrative and they're like, take this antibiotic and this herb, or something like that, where I'm kind of digging through and I'm like, okay, well, great, and why did this happen? Like, why did you get SIBO, small intestine bacterial overgrowth? Or why are you so tired when your TSH looks normal even though you have Hashimoto's? Is there something else missing here? So we just kind of dig, and I'm very much a data digger. So I like testing. I like good answers. I don't like throwing stuff at the wall and seeing what sticks. I find that incredibly irresponsible when people do that. So yeah, and so I have real information to share with them, and then we track it in real time. And so that's my approach with things, is like, okay, we're going to watch this over time, like you would watch cholesterol and you would watch these things over time. And I watch that with all the different aspects of it, like,
Yeah. So what you described to me is what I think of as exceptional healthcare. One, you're building a relationship with your patients. Like you have the time to understand them. That's incredibly rare in an insurance practice anymore, if it even exists. I don't know if people really, have doctor-patient relationships much in a 7-minute office visit. And then part of that is that you have an ongoing relationship with them as well, it sounds like, and that's,
yeah.
I think that's the key factor, is that if if you have time with them so you can understand what their goals are, what their questions are, what's going on with them, you are doing an assessment so that you can figure out what, what the baseline is, where things are, maybe start setting some goals on what you want to accomplish, and then implement a strategy, right? Okay, well, we're going to do this, and we're going to see. That's how people get results, in my experience. Sounds like that's what you've
And
developed.
we're also, I kind of look at it, so kind of take a step back. My career actually took a couple of turns, because at one point I thought I was going to birth babies. And so I did my intern with a midwife before I went into family practice residency, and then I decided I didn't want to birth babies any longer. But what I really loved about it was the idea of birthing a baby and then following them through their life and then birthing their babies, right?
Yeah.
And it didn't have to be that way, I realized. It was that I was really empowering people to be healthier parents. And so now I have like 3 and 4 generations. It's like a big joke that like people will show up in my waiting room and they'll be like, oh my gosh, I didn't know you came here. And it's like all these people kind of know each other because referrals over referrals and referrals, and it kind of goes 6 degrees of separation in there. But it really is beautiful because we're not just treating like that person in front of us, we're empowering them to make healthier decisions and really understand what they're doing on a daily basis and how it's impacting their health. And so that's affecting their parents and their siblings and their kids. And so it becomes this like, well, I am only one person and can do this. We have the power to do all of this. An insurance model doesn't allow us to do that because we have those 7 minutes, which I've also worked within the insurance model. So it's been beautiful to step outside of that and be able to do the kind of medicine I think we should be doing.
Yeah, I talk to patients a lot who are frustrated with healthcare, the experience that they've had, and they will sometimes say, well, the doctor had no time for me, blaming the doctor. And I'm like, okay, let me give you a different perspective on that. Because none of us went into medicine to spend 7 minutes seeing patients. Like I don't know about you, but when I've been in that environment where I'm, you're seeing 20 plus patients in a day, it's draining. And you feel it's frustrating as well because you never get a chance to really do, you always leave with some uncertainty. Like, I wish I would have had more time to do this or that. And you just can't do that in an insurance model. But I think, I was just talking about this with somebody today, is that I think the world is understanding now. Like there was a time when it was like, well, if it's not covered by my insurance, I'm not interested. I'm not going to do that. People are now realizing insurance is, if you're just doing what your insurance will pay for, that it's going to cost you a lot more than the money you would have spent likely. Has that been your experience as well?
Yeah, I tell people you'll spend more upfront and you're going to gain back a lot of money, time, and energy in the long run. Because
it's an investment, right?
It's an investment up front,
Right.
especially with testing. I think people are more aware because they have more access than ever. And so I think that that's really wonderful. They're aware of they're starting to become aware that it's not really the doctor, that it is the insurance model, as they watch doctors on TikTok talk about how we spend hours and hours on, prior auths and things like that.
Yep.
And they're called out of emergency rooms because that wasn't an approved surgery, even though it's a life-saving surgery. And you're just like, oh my gosh, this is the reality of it. And so now they can kind of see how that happens and maybe a little less likely to blame the doctors if they're paying attention to that. And then, other pieces of it is that there's this misunderstanding that if you pay out of pocket, you're paying more. And so that's always really interesting. Like here's a good example. So a patient needed an MRI of her brain. And so her, neurologist ordered an MRI and her insurance rejected it. And so they're going through this whole process back and forth like we always do, like so well. And I said, okay, well, that MRI is $250 cash pay. Can we just go ahead and do that and get this done? Because you need an MRI now. And she was like, what? And so she calls her neurologist and she said, can you rewrite this? And he said, no, you can't do that. I can't do that. I can't write for a cash pay MRI. Yes, you can. Of course you can. Nobody has to use their insurance. And so she came back to me, and I'm trying not to step on toes. Like, I'm always trying to be super respectful, and I'm saying, like, hey, this is this, but your neurologist is your neurologist. I'd like to not step on toes. We're doing, collaborative care here. And so I ended up writing it, and I'm like, here, this is $250 rather than $1,000, and your insurance approved it, and you're still paying $600 or whatever. So there's so many cash pay options out there. It's like, a cash pay PAP is $30. Like, why are we sending people to collections when we can do $3,000 of labs for $250 cash pay? And so there's a lot of loopholes that way that people just don't know they have access to. It's kind of like GoodRx for prescriptions, right?
Yeah.
We have all of these things. Sometimes we can compound medications, like I was talking about at that meeting. Like that family I had, the little girl got pinworms. Pinworms just stink. The whole family has it at that point in time. And the medication was $600. And so it's like $600 for one of them. And she had celiac And so we were able to get her compounded medication. It was $40, and we were able to get enough that the whole family was able to be treated for, almost nothing. So
it is a surprise. I mean, it is a surprise to me. I was an employed physician, most of my career until I opened my practice. So I knew nothing about billing or money. And it was a blessing in its way, when I was at Mayo, is that I just recommended what I thought was right for my patient. I didn't worry about what it paid. And I didn't worry about what I got paid because I was on a salary. But you're exactly right. There's price transparency in medicine that doesn't even exist. Yeah. And I was just having a conversation with one of our people we know, a doctor that we both know. I'm going to see her, and I was just talking about. She's like, "Oh yeah, well you can get an X-ray for $60, and if you need an MRI, it's $350." And I'm like, "No way!" Like I'm like, it has to be $4,000 to get an MRI. Right. No, apparently not.
No.
Yeah.
It's fantastic. There's all of these other options, but I recently went to my gynecologist and had some testing done, and cash pay options weren't even in her. I was like, "Oh, I can order this myself and get it cash pay," and she was like, really just thrown for it. And I'm like, "Okay, well, I'm not going to step on your toes, but like this is a lot less expensive, and these options exist."
Right, yeah. It's you're right. I think that commercialization is coming to medicine. There was a time way back in the day, for example, like a travel agent. You wanted to go on a big trip, well, you had to go find a travel agent, right? And then they went out and set everything up for you. But eventually you could just do it yourself. And it was faster and a lot cheaper and all those things. That same thing is coming to medicine as well. And so you talked about doing comprehensive testing. Give me an idea, if you don't mind. Like you see a new patient, they don't have any specific complaints, just hey, I want to stay well. General. What kind of things are you looking for in them? What kind of testing is important to you?
I would say that's about 1% of my patients.
Okay,
so it's not my most common. However, I would really love it, so if anybody's healthy and wants to come see me, that'd be great. It's a lot less work, but I usually start with a good smattering of labs, more so than they would get kind of. Generally, when people go to their primary care, they get a CBC, a CMP, a lipid panel, maybe a CRPHS, right? Maybe a couple of other things. And if they're really lucky, they throw in a vitamin D because half of the insurance companies call it experimental.
Right.
And you're like, that's great. This is experimental vitamin D. And so when we start, I'm looking at all of their hormones. No matter what, I'm looking at all their hormones, iron, vitamin D, looking at their thyroid antibodies. So I'll look at, there's basic vitamins I run on every single patient, which is D, iron, A, zinc, and C, and B6. And so those are like my baselines of, we can do, and iodine, sorry, one more. But those are things that impact a lot. So like I shouldn't be really looking at their thyroid without pulling an iodine if they're a thyroid patient. Now, if they have other things, I'm going to start to look at that differently. Like this chronic fatigue patient, and they don't really know, but they've already rolled out a lot of the big scaries. Maybe I'll run a viral panel on them and see, like, could it be Epstein-Barr reactivated? And there are titer panels where you can look at early antigen and IgM in addition to, obviously, the past history that'll always be there. Or cytomegalovirus. I had a patient who was hospitalized, and he was super sick for months and months, and then they discovered that it was cytomegalovirus. So there's these viruses outside, of like COVID that were causing all these long haul symptoms long before. Is it somebody who had a ton of strep growing up and now they're having OCD behaviors and they're like, my mental health is really declining. I feel really sick all the time. I have all these health problems. And then you're thinking, okay, well, you shouldn't have strep antibodies if the last time you had strep was 10 years ago and you had your tonsils removed. And so might throw some strep antibodies in there and to see what the titer levels are. And the titer levels say they should have had it in the last few months and they haven't. Maybe we need to address that. And then in that case, since they no longer have tonsils, you and I know bacteria and infectious disease. I feel like sometimes in medicine we almost oversimplify just to move on quickly. And so strep is like one of my favorites where it's like, okay, you get strep because it's an infection that somebody gave you, right? And you touched a surface and they coughed in the air, whatever it is. But when you get your tonsils out, what really happens, right? So do you stop getting strep? Did that surface no longer get contaminated? Did no one around you ever get strep again?
Right.
Or did you just swallow it because that was your first place to stop the invader and the infection? Just like our skin, just like our snot, just like these things that we know at the most basic level, but nobody talks about. I've never heard anybody talk about that. And so that person, if I'm doing that, I might want to run a stool panel on them and see if they have large amounts of strep in their stool. Because it can get past the stomach acid for some people.
How do you, do you send those lab tests for to insurance, or is this just you have a way to do these cash pay at a good price?
Yeah, it depends. So I always try and run everything I can through insurance, right?
People pay a lot of money for insurance.
Exactly. And I'm trying to use it,
right.
and I'm trying to work the system for them. When it comes to other tests, though, we know that like we can send testing in for stool into SonoraQuest or LabCorp, and they're like almost always going to miss it. I mean, just stool testing is so archaic. They're still using really old methods. So for stool testing, there's also the downfalls to the stool tests on the market. So I'm always super verbal about this because there's a lot of stool tests now. And people are like, oh, I have C. diff. It came up on my stool test. And I'm like, really? Because your stools are formed? Like, we know in healthcare, we're like, somebody has C. diff. I'm putting like antiseptic, stuff up my nose. I don't want to get it so badly. And so it was like, no, you don't have C. diff. Like, yes, it came up on PCR, but that was years ago. So PCR has its downfalls. We know that from COVID testing. People now know what PCR testing is outside of medicine. Right. And so I use a company that does microscopy, culture and sensitivity, and PCR. And so it does all three so that I can take all three. And the culture and sensitivity does against natural agents and pharmaceutical so that we're not guessing. So if I can find a company that's really good at one thing, I'll use that one company. And so I use a company that does that. And then I'll overlap it with, what's going on. So if it's PCR and it comes up with C. diff and they have formed stools, obviously it's not C. diff.
Right.
And I'm not even worried about that. I'm going to discard that. Whereas if it comes up with strep and it, or yeast is a really fun and interesting one because I think people get behind this idea that everybody has parasites and everyone has yeast, and I don't agree with that. But I do see parasites coming up quite a bit, and I do see yeast quite a bit. And if a culture is out, everyone thinks Candida, but there's Rhodotorula and Geotrichum and all these weird little strains, and those ones cause different things. So I had a woman develop agoraphobia after she got sick in Mexico, and she was treated for UTIs, and she ended up at Mayo, and so she went through the gamut of all the specialties, and they just thought she was kind of crazy at the end, right? So they've got her on psych meds, and she is doubled over, in pain, nauseous, can't eat, is losing a ton of weight at this point, and she's developed agoraphobia on top of it, and she's just so fearful. And so, I mean, just so messy. We ran a stool panel. She had Rhodotorula. It was the first time I actually saw that strain, and so I really didn't know how impactful it would be, but I said, I really think that we should start you on an antifungal medication. And I remember having this conversation with her Mayo doc, and her Mayo doc was like, I think it was, I don't even remember what specialty any longer, because I was trying to coordinate care and be like respectful and do this the right way. And I was like, this is what I have. I'd like to put her on an antifungal, but I think there was a medication she was on otherwise that there was an issue with. And she goes, well, that's not evidence-based medicine. And I was like, okay. You have her on all of these medications that were off-label, mind you. Those aren't evidence-based. Like, we use medications all the time off-label, right? We don't necessarily know the mechanism of action for many medications. We know some of them. So it was just like, it really, really hit me. And the woman came in and she was fearful and she was not following anything. This was like a couple months where she was calling me, like calling the resident on call in the middle of the night and all these things. And so finally I sat her down and I said, okay, here's the thing. I don't want you to waste any more money with me. Like, don't come back. I don't want you to waste money. I want to care for you. I need you to follow through and do what I'm telling you to do. And if it doesn't work, then we'll try something else. But at the same time, I don't feel ethical in taking any more money when you just come in every time and say, no, I didn't do that because my Mayo docs told me not to. And so we ended up putting her on nystatin, not even like diflucan, but nystatin because I wanted it to stay in the gut because that's where I knew it was. 3 days later, she calls me and she says, all my symptoms are gone. 3 days.
Wow.
This was 2 years of her life.
Wow.
And it's like, okay, well, I guess Rhodotorula is a bigger deal than I thought.
Yeah.
And I've seen it a bunch of times since, and it does. Very often it has like mental health capacity. And now, zoom forward, this is probably like 10, 12 years ago, zoom forward, now we have these studies that show that, the gut bacteria are talking to our mitochondria and they're actually cross-talking, and there's all these cool things happening. And so we're like, oh, it turns out it wasn't so crazy. It's just science needed to catch up a little bit there. But ultimately, at the end of the day, I still had a stool panel. It wasn't like I was like, put my hands over you and I think you're yeast. So
use the Star Trek machine to plug her in and say,
fantastic.
okay, this is what you have.
I love it.
It's one of those things I've noticed, and I mean, I've been a physician now 30 years, and the insights, like things that we thought were absolutely crazy back in the past, turned out to be true.
Yeah.
Some of the things that we were convinced were, there was no debate about them, turned out they were false. Like it really is fascinating how things evolve in this. And I think, the best doctors keep an open mind. There's not a lot of open-mindedness though in medicine. So what an incredible story. Is most of your patients, are you their primary care doctor, or are you more of a consultant role for people?
Most of my patients end up transferring in for primary care unless they're being managed by a primary care that sends them in. I try and be very thoughtful about that. So, make sure I do my portion of it and send them back, and not trying to poach people, from their primary cares. I want that good, healthy relationship, and they have long-term relationships with their primary care. But a lot of people end up just bringing their care in because I'm a little neurotic. Like, I'm definitely going to make sure that they get a full physical exam every year. I'm going to make sure that, everything is done correctly. And so they know that things aren't going to fall through the cracks. But there's also, in all honesty, it's like, I know that Beth went on vacation, and when she comes in to see me, I'm going to ask her about her vacation, or so-and-so got married, or so-and-so had a baby. We send them a card. They just had a baby. I care about that, and I'm like, hey, I hope Cameron's doing well. And you're like, I love that relationship piece of it. And so most of them stay because of that, or like, even like, I've chosen to have a paramedic in my office. I don't need a paramedic. But I really love her skill level, and so she's fantastic. And so instead of having an MA or a phlebotomist, I have a paramedic, and she just goes in and gets the hardest sticks. And then for that, what's important about that piece though is that, I mean, she was putting IV, caths in on an ambulance that was moving while somebody was dying.
Yeah.
That I'm taking the fear out of medicine for patients, and a lot of that might be blood draws for those, or kids, or suddenly they're like, oh, are you done?
Yeah.
I was like, so it's really that experience for them. Like, we might come in, put them in a private room, lay them down. We've got a lavender mask and a distractor for the really hard ones.
Yeah.
It's like, they get a lot of
great experience.
Yeah.
Well, I think that, that's a common personality trait in really good physicians, is being a little OCD, and that's what you just described. I know a lot of people are going to be listening to this podcast, and they're going to say, okay, I need to know more about Dr. Geyer, her practice. If somebody's interested in coming to see you as a patient, how do they connect with you?
They can do it through my website, or they can do it through phone, either way. The website's EmpowerIntegrativeHealth.com. And phone number is 602-345-1605. Kayla's my new patient coordinator. So what she does is she onboards them, and she's very, very good at being like extremely transparent and over explaining the experience to them so that there's no surprises, because I don't like surprises myself.
Mm-hmm.
So I want them to understand like what it looks like. Their first appointment will be 90 minutes with me. Their second appointment will be 90 minutes with me 3 weeks later. And so we meet, we talk about everything. I do a full physical exam, we do imaging, we do labs, we do whatever, we get records, we do all of these things. They come back, I go through, and then I teach them about it. And then we talk about different treatment options. And so one thing I think is super important is that people have to choose the right treatment options for themselves. And so when I sit down with them and I say, okay, well, there's this, and these are the treatment options. Not everybody's going to choose the same options. They may not be the right ones for them. So somebody might choose, let's say it's really easy and it's a UTI. Okay. Somebody might choose antibiotics or herbs. Well, we know with E. coli that herbs are almost as effective for urinary tract infections, or D. mannos. D. mannos is well studied for E. coli. So we know that, and then I can sit down and say, okay, we can do that, or we can do this. But if we're going to do antibiotics, then we should make sure that we do probiotics on the other side, and that we retest, which I feel like is something missing a lot, is that we send them off, we treat their bacterial vaginosis or their urinary tract infection or anything really, right? And we just send them off, we say this infection is gone. Do we know that? Are they just getting repeat UTIs and vaginal infections and yeast infections and all these things because it never fully went away? So that's where, some of the things come in. And then after that, it really depends on the person. So most people I'm only seeing like every 3 to 6 months. I have people that come in just for their annuals. Some people need to follow up a little bit closer, and we might be like actively doing therapies for them in the office, because we use a lot of therapies that people may not think about. So my diabetic patients, I'm going to have on a continuous glucose monitor, and we're going to meet monthly. And then if I'm doing therapies that I am worried about their muscle mass, I'm going to do body impedance analysis and watch their muscle mass with them. So some of that's a little bit more, like shorter term visit follow-ups, but yeah, that's the flow of the office for the most part.
Yeah, it's interesting that you say like CGM, continuous glucose monitoring, or body composition, tools that I never used in 20 years of practice, 2 years of doing this practice. I don't know how I was able to guide people without that information. Like, it's so valuable, and I just had to get outside of that box of doing what the guidelines say, and understanding, okay, well, what's right for the patient? Like, what can I do here? Where can I gather information that's going to help them and me, make decisions for them? And there's a lot of really valuable tools like that we have.
Yeah, so many cool things we have right now. It's like just such a cool time to be in medicine. It's hard to imagine, and I still have my friends and colleagues of, every walk and specialty who are like, oh, you can't do that, you can't do that. And I'm like, how? I don't feel like you can really live in the world right now and just pretend none of this is happening.
Yeah.
Like that we are learning all of these beautiful things, that there are studies coming out. Like, why does it take medicine 15 years to catch up with the studies?
We are really behind the times. Yeah. Like it takes so long for change. Even really strong evidence-based therapies will, they'll be out 5 years, and then there'll be a study saying, well, 11% of eligible patients are on this treatment. And you're exactly right about that. And it's just going to continue to escalate. Like, we're on an exponential curve of learning and insights and things. And as you say, it really is a very exciting time to be in medicine and healthcare.
I love it. And I think it's so interesting. So a lot of medicine is still, a lot of physicians are still looking at things kind of one-dimensional, right? And maybe two-dimensional. And I always tell patients I'm looking at things in that three-dimensional way of like, how many things can we look at? Like, if I'm looking at blood sugar, this is a really good example. I had this conversation with somebody yesterday where I said, okay, years ago, we would look at fasting blood glucose, right? And so we looked at fasting glucose and we said, oh, well, you need 3 elevated and then you're diabetic. That was so terrible because some people are elevated every morning, but then they regulate throughout the day and they're not diabetic. So then we learned that, that doesn't work. We should use a hemoglobin A1C. And so we're like, okay, well, hemoglobin A1C is a snapshot of your blood sugar over 3 months. Hey, maybe I'll throw in an insulin. And so when I'm looking at this with somebody who has blood sugar issues or, chronic fatigue or metabolic issues or any of these things, because as a cardiologist, the blood sugar affects your cholesterol and lots of other things. So I'm looking at fasting blood sugar, hemoglobin A1C, insulin, and a glycomark, because glycomark tells you about blood sugar fluctuations for 1 to 2 weeks before they came in.
Right.
Now you've built a 3D picture, add on a continuous glucose monitor, they write down what they're eating in there. We say, hey, when you eat corn, your blood sugar goes up 80 points. So my husband and I wore a continuous glucose monitor when I was bringing him in for non-diabetics. I wanted to see how this would work for a non-diabetic. Right. And my blood sugar shoots through the roof with corn, but I can eat bread all day.
Yeah.
His shoots through the roof with bread, right? And so from CGMs that this is like really cool. My blood sugar drops if I have a beer, 30 points. His goes up like 50 points.
There's
It's
so much
amazing.
individual variation.
Yeah.
Like you can't say one size fits all, and that's one of the limitations of traditional medicine. Very algorithmic. Like you do this, then you get this, and then you have that, and that just doesn't address the reality of the complexity of the individual variation. And that's another one. Fasting insulin. I never ordered those before. Now I don't know how I worked. Did without
Yeah.
that, and I still remember very distinctly a grand rounds at Mayo Clinic, the head of endocrinology giving a talk and adamantly saying in this talk that it was nonsense that people were using an A1C to diagnose diabetes, that nowhere ever has it been recommended to use an A1C for diagnosing diabetes. Of course, now it is, but this was maybe 10 years ago or whatever.
Yeah.
And I remember thinking like, gosh, it just seems like it's so much smarter to use an A1C than, okay, we're going to do a fasting glucose and then we'll do an oral glucose tolerance test and all those things. Well, how about an A1C? And so you're exactly right. Well, Dr. Geyer, it's just been a real pleasure. I can't believe the time has passed so quickly, but thank you for joining us, and really congratulations on your practice and the exciting work that you're doing for patients. Thank you for all you do.
Thank you so much for having me. This is fun.
All content created by me and HealthspanMD is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Hi, I'm Dr. Hurst. We created HealthspanMD for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or a procedure for optimizing health. This type of healthcare is unacceptable, but most aren't aware that they don't have to accept low-quality healthcare. HealthspanMD provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMD patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality health care, schedule an appointment at HealthspanMD to experience health care as it should be.